And we are live already. Good morning, I will say to you all. And just going to multitask and get my computer doing this as well. There I am. That way I can read the comments as we go. Alrighty. So we've got an audience. I don't need many people. They'll come along in due course. So I will try and keep things going with the questions. So I've got a list of questions already, which is great. So let me do those, and then we'll see how we go with catching up to any new questions. So one of the questions I've been asked repeatedly as a topic to talk about is something called laryngomalacia. Now, laryngomalacia is a bit of a mouthful, but I'll break it down into very simple terms. Laryngo gives us a clue. It's about the larynx, which is the voice box, and malacia refers to basically what we would call it being weak and floppy. So laryngomalacia is a weak and floppy voice box, and it is a condition that presents in infancy. Usually the child is absolutely fine for the first few weeks, and then typically on average at around about week 6 they start to develop some noisy breathing. Now, the noisy breathing that they develop is not snoring. It's a very distinct noise. It's a noise that we call stridor. And stridor is a noise that's made from airway obstruction, but it's different level of obstruction to what snoring's made at. So snoring's all about nose and throat. And then lower down we have the voice box and we have the windpipe. So apart from laryngomalacia, you can also have the windpipes known as the tracheas. You can have tracheomalacia or tracheomalacia. And then lower down the trachea breaks off into 2, which are called the bronchi. So you can even have bronchomalacia. But let's just stick with laryngomalacia. So laryngomalacia, they get, as I said, this noise called stridor, which is sort of like a noise as opposed to a snoring noise. Okay, so 2 different noises. And the most common cause of stridor is laryngomalacia. So when a little infant is presenting with the stridor noise, the most common diagnosis that gets made is laryngomalacia, just by virtue of the fact that it's the most likely. Now, the problem is it's not the only one. There are other causes of stridor, and given that that's the case, there can be problems with misdiagnosis and missed diagnoses because of that assumption. The other typical time that an infant going into childhood will get stridor is when they have an infective condition, which is a viral condition that affects just below the level of the vocal cords within the voice box, and that is what we call croup. And the treatment and management of that's very different. That child's sick and unwell all of a sudden. So the laryngomalacia, they're not sick, they're not unwell, but they develop this squeaky breathing noise. And it's usually most evident when they're active, and the 2 scenarios where that's most prevalent is when they're feeding, and then also when they're crying. And as they get older, when they start to move as well, they can have an impact. But the most common times is when they are feeding and crying. And when it's a mild case, and it sounds a little bit vague, but it's a clinical assessment. When it's a mild case and they're otherwise growing well, like their growth curves and so forth is okay, they're able to feed adequately and properly, and they are not having episodes where they're turning blue, then we definitely tend to sit back and just wait and ride it out, because they, generally speaking, tend to get better by themselves. The trickier cases are the cases where they are not turning blue and they are still sort of gaining weight and feeding, but they're really struggling with it. And the reason they're the tricky cases is because the kids that do turn blue and stop growing and stop feeding, we do fix. So we have this in the middle territory, that, this grey zone of assessment that makes life tricky. And I've sat in rooms with excellent skilled practitioners, very knowledgeable, and one of the things that they did is actually had a mock debate where they had the for and against of should we perform surgery in laryngomalacia, because it is a form of airway obstruction, and as you know, listening to me rant and rave, we shouldn't ignore children that are not breathing properly. We need to intervene. The reason that it gets a little bit complicated with laryngomalacia is that there are potential downsides to the treatment, which is surgical, and it's surgery within the voice box where we are trying to treat areas of tightness and tension and release that to open up the space. One of the consequences potentially is that one of the many jobs of the voice box is to stop aspiration, so stop when they're sort of breastfeeding or bottle feeding, if they're doing that, is to stop the milk going down into the lungs. And if we open up the voice box, it can become incompetent for a while, and then we end up having to feed the baby via tube. So that, there is a downside to it. We do have a middle of the ground approach, and that is that not uncommonly the laryngomalacia is associated with reflux, and that reflux causes swelling within the voice box, and by treating that we can lessen the symptoms. So we have a middle of the ground medication approach, which is a great sort of option. And then the thing that is emerging to try and make us all a little bit more objective is to proceed to have a sleep study in these children to get some sense of what degree of airway obstruction they do have, and then trying to then formulate, using the answers that we get, whether maybe we should be more proactive in intervening or not. And then the other thing that we are starting to do is prospectively look at the outcomes, like we are in the children with the snoring and mouth breathing, to see, okay, what happened to these children with laryngomalacia? How long did they have it for, having elected to just let them ride it out? And what were the consequences of doing so? Are we making the right decisions by being conservative? Are we causing other problems down the track that we're oblivious to? So that's laryngomalacia. The one thing I would add as an important thing, as I said, is that it is not the only cause of stridor. There are a multitude of other causes, and the only reliable 100% way you know what's going on is to have a full endoscopic, telescopic assessment. And whilst I, as a starting point, will do the nasal one, where I put my little telescope through the nose, down, look into the voice box level, and can identify pictures and patterns consistent with laryngomalacia. The problem is I can't look down the windpipe and down further into the lungs. So the only 100% definitive way to know what's going on is to actually have a look, but under a general anaesthetic. Now that is clearly overkill for many of these mild cases. but putting the nasal telescope down, which is very easy to do in babies, surprisingly, for those uninitiated to it all, is actually extremely easy. It does not require a full anaesthetic. It is obviously distressful at the moment that it's done, but it's a very quick thing. At least narrows down the fact that we're dealing with laryngomalacia versus other things that I've seen. I'll troll through my library perhaps and share some down the track. For example, though, is you can get a cyst, a swelling of fluid that grows somewhere in and around the voice box or in the windpipe even. Or you can have a physical narrowing of some sort. You can have rare malignancies and tumours in newborn infants causing problems. You can have a paralysed vocal cord where one of the vocal cords is not moving, causing problems that are all very similar in symptoms to laryngomalacia because they have stridor. So that's the laryngomalacia one, so hopefully that helps you all there. The next thing that I have on my list was a question about sleep studies in children. Now, I'm going to tell you all very, very upfront, I'm very biased, and that bias may cloud my judgment and viewpoint on things at times, but my answer with regards to this comes from the scientific literature and just thinking things through logically. So a paediatric sleep study, there are different, regardless of paediatric or adult, there are different levels of sleep studies in the first place. And when it comes to a paediatric sleep study, when we are measuring the breathing and the sleep, the primary information we get from a paediatric sleep study is, does this child have obstructive sleep apnea? That's the main thing that we find. And that's great, obviously, to determine if they've got obstructive sleep apnea. But when we look then at the literature to go, and this is before, this literature was actually before the era of mobile phone technology. They did the research where they basically were asking parents some pretty good questions, including, does your child stop breathing at night? And then they found that the parents were actually pretty good when they've been vigilant and watching over things to actually work out which ones had obstructive sleep apnea. That was backed up by a sleep study. In this day and age, the parents can just go and video their kids. Just go and take a video. If you think your child is stopping breathing and you're seeing them stopping breathing, go take a video and we can see that it's happening and go, all right, well, there we go. We can confirm that you are right. So that can get one way around getting a sleep study in that respect. But this is where we run into a problem. The pathology spectrum of airway obstruction in paediatrics includes obstructive sleep apnea, but that's it at the extreme end of it. The other problem is that the beginning point is actually mouth breathing. And its next step along from there is persistent snoring. And the next step along from there is something called upper airways resistance syndrome. Now, when it comes to upper airways resistance syndrome, we can actually diagnose that using a sleep study, but only if we do the full testing. And what that entails is using a little tube, a bit like my nasal telescope, but a little tube that goes down through the nose and goes and sits in the middle of the chest where the esophagus is. And that little tube is a pressure monitor. And what it senses is it senses when you take a breath in, for example, so when you breathe in, what happens is the diaphragm goes down, the chest cavity goes out, and that creates a negative pressure which draws the air in. And when you've got this little tube going down, then you can detect that there's been a pressure drop, okay? So it detects the pressure changes within the chest. The other thing that you have is that you have something that either measures the chest expansion, or you can measure the little muscle electrical activity in the chest to know that a breath was taken. So if you measure breath was taken, then the pressure goes up. Pressure goes down, pressure change, technically, pressure goes down. When you take a breath in, then they match up. So you can determine when someone took a breath. The other thing you can do then is you can measure the amount of airflow that went through the mouth or nose, because that's partly how we measure when there's an apnea. And what we can pick up is that we can pick up an increase, there could be normal amount of airflow, but that's because there's been a much greater effort in terms of taking that breath to get that air in. So for example, I'm here sitting at the moment just breathing quietly as I am. Someone comes up to sort of, smother me, but doesn't fully suffocate me, I'll still be able to breathe to some degree, but I've got to work harder to do it. That is something that we can pick up. The problem is that we don't, as a routine, use that pressure tube. So that pressure tube goes in the esophagus, so it's called an esophageal manometry, which means pressure measurement. So we don't do that as a routine. So we don't, as a routine, diagnose upper airways resistance syndrome because we don't use that technology. And then the next problem we've got is that we have just the snoring. Now, you will have usually a microphone system where you'll pick up the fact that there's snoring. But the problem with snoring is that it doesn't have to be all the time. What we call habitual snoring, which doesn't, by the way, mean habit. The English language is a very confounding creature. Habitual does not mean habit. They sound the same, but in English, they actually mean different things. Habitual just means doing something regularly. Habit means doing it for no particular reason other than it's just a learned behaviour. So they actually have different meanings. So habitual snoring is thought to be pathological when it's 4 nights of the week or more. So you could have a sleep study one night where there is no snoring, but that doesn't necessarily mean that that's representative of the child in its entirety. And then you have the issue with mouth breathing. That's something that's more an observation rather than a measurement. So again, you can run into problems there. So this is the long answer to the question about personally for me with sleep studies in children is that I go far more by clinical grounds rather than anything else. And the reason for that is that a normal sleep study does not mean normal breathing. So from that point of view, I like to sharpen my clinical acumen and ask pertinent questions, and also then make thorough clinical assessments to appraise a child for potential upper airway obstruction. And I think that might actually lead into another comment that had popped up, which seems to have disappeared, but that's all right. I've got a good memory for these things. So there was a query about how do I know if my 4-year-old has a problem? Well, first up, this is not advice. This is a discussion. So the answer is not specifically relevant to any particular case, person, or event. It's just a general chit chat. So the way that I'll answer this is to say, how do I make a clinical assessment? And my clinical assessment is history and examination. And the pertinent things about history, in terms of where I start the ball rolling, does your kid snore? All right. You notice that your child is snoring. And it's interesting when I ask that question sometimes, because some parents will go, no, not that bad. So that's a yes. We're not looking to quantify it with a does your child snore question. We're just basically trying to qualify it as a yes or no. And if the answer is yes, then we can go into, all right, is it all the time? Is it now and then? Is it some nights, not other nights? Is it part of the night, the whole night? Is it more so circumstantial when they're tired or got a cold or allergies playing up? So there's different elements with regards to that situation. Then ask about mouth breathing, okay? Mouth open or closed at night. And then I ask a whole range of other associated things. So I'll ask about things like sleepwalking and sleep talking and night terrors and teeth grinding, because they are all elements of sleep disruptive behaviours, which can sometimes be associated with airway obstruction. I want to know if they're restless at night, tossing and turning, sweating at night, if they're wetting the bed still beyond an age where you would have thought they would have stopped. When they're asleep, are they sleeping with their head arched back? I've had a recent video that I put up. If you jump onto this page and scroll back, or if you go through our YouTube page, where I talked about that body position basically being the mouth-to-mouth, resus heart position, which basically the child is doing first aid on themselves to open up their airway. I want to know, what impact is this having? Are they waking up tired? That's probably one of the most pertinent questions to ask when you're appraising this, to look at what impact are these sleep disturbances having. Are they waking up tired? And then building on that, we want to know about the daytime function issues. So. And it can be children, and what we're trying to do is establish, is there something along the line that seems out of the ordinary? And we're looking at things like behaviour, energy levels, emotions, education outcomes, concentration. And again, what sadly happens sometimes is the reply is, oh, well, they're just 2, what do you expect? Or they're just 3, what do you expect? Or, yeah, they're getting a bit cheeky, now I'm playing up because they're 6. That's not a rule. We've created these things like the terrible 2s to somehow try and give us an excuse to socially say to someone, oh, I'm so sorry about their behaviour, they're just going through their terrible 2s. It may be that if a child is not breathing and sleeping properly and waking up tired, which starts to really manifest mostly at the ages of around 2, 3, 4, 5 and 6, that they're actually having a breathing problem. But the relationship wasn't formulated by the parent, which is fair enough because you don't know what you don't know. So that's something to be mindful of with respect to those sorts of daytime issues. The other thing then that I want to know is, the general thing, do they get hay fever, allergy or asthma? Because they can tie in with airway and breathing problems. I also want to know about whether they've got, problems with their hearing, because around about 20-ish% of children will have a build-up of fluid behind their eardrums when they've got upper airway obstruction, but not necessarily be having ear infections. So they can be walking around partly deaf because their head's basically underwater, which of course can affect learning, concentration, behaviour. So it can have a dual effect. They can be tired and deaf, which is an absolute disaster for education outcomes. And then building on that, you want to know about the infective bit, you want to know about the tonsillitis, you want to know about the ear infections. But by about that stage, at least when it comes to tonsillitis, I'm pretty disinterested, quite frankly, as to whether that's part of the story or not, because if they've got airway obstruction and I'm having a look inside and seeing massive tonsils, I don't care about tonsillitis. It's a completely irrelevant part of the conversation. But of course, we ask about it because it's part of just formulating the clinical case. So that's your history bit. And then I jump over to the examination, and my job's pretty easy. I look inside the ears, nose and throat. Sometimes it really is simple. People can overthink these things sometimes, and I can give you the overthought, story as well. But basically, I look inside the ears. What I'm looking for is any fluid behind the eardrum. Easy. I look inside the nose, and there's different ways I may need to do that. I always look inside the nose though. Even these little ones coming in for some other reason, I look inside the nose, because you don't know if you don't look, and if you don't look you won't find, if you don't find you can't fix. And it's staggering to me how many people, and this is adults too, have had assessments at some stage and have breathing symptoms, but no one's looked inside the nose. So I have a look inside the nose, and what I'm looking for at the front of the nose is I'm looking for the calibre of the nasal passages. I'm looking for the position of the middle part of the nose called the septum. I'm looking, if it sort of represent the nose projected out, I'm looking for swellings inside the nose, which were called turbinates, to see if they're big or small, to sort of get an idea of space that's available. And then if I get an opportune look, I'm able to see through the nasal passage if that part's clear and open nicely, and get an idea of, what do the adenoids look like in the distance. But there is a limitation to how well that can be appraised. So I do have my little nasal telescope to go inside the nose and have a look-see. Most children, which is not all children, most children will let me do it when it comes to it. I turn it into a game, as I do with lots of things, just as a distraction, so that the assessment is thorough. And then the next thing I do is look inside the mouth. Now, everyone would obviously conclude that I look inside the mouth and look at the tonsils, and you're absolutely right, I do that. But I don't stop at that point. I look at the tongue. The tongue's there, you might as well look at it. I look at it on the top, but I also look at it from underneath. I'm looking at it from underneath with respect to, do they have a tongue tie? Because I want to know if there's any, what we call oro, which means mouth, okay, motor function, oromotor muscle, oromotor function issues, which a tongue tie is one. And the other thing that I want to know about is I want to know about the skeletal framework that we're dealing with. So initially I can see that from just looking outside, because you can see what the face looks like. But then look on the inside. I want to know what's the configuration of the upper and lower jaw. Is the upper jaw got squashed in, and as a result of that, the palate, which is this bit, is sitting high, or we call it high arch palate, and squashed in so that it's narrow? Has that caused the lower jaw to get trapped and is holding it back, so the lower jaw is not growing forwards as it should? And the reason those things are relevant is because they are constrictions. Those constrictions to the skeletal framework not only reduce the airway calibre, but they change the dimension or the shape of the airway. And the reason that that's important is that we can measure the size of the airway, okay? But it also depends on what shape the airway is as to how well air will flow through it. And the best shape is circular, and as it becomes more of an oval shape, even if what we call the cross-sectional area is the same, the amount that we can actually put into it is different. And I'll give you an extreme example to prove that. You've got your car, you're driving it into a car park space, okay? That car park space is a certain depth and a certain width, and by virtue of that, we can measure the area of that car park space, all right? Now, we could make that car park space a lot narrower and a lot longer to compensate, such that the area of that car parking space is exactly the same, okay? So the area is the same. Clearly, you're not going to get your car into that reconfigured car parking space. And it's the same with airflow. It's airflow follows a line of mathematics called fluid computational dynamics, or fluid dynamics, okay? And they're basically the rules of physics as to how things flow through tubes. And when the tube is round, is optimized, versus oval shaped. And when you have a narrow face, basically it's like getting a circle and you're squashing it, and it will come in on the edges and then pop out at the sides, and that's exactly what happens. So it's not just the space, but it's also the configuration of the space too. So that's the other thing I'm looking at, and the reason that I'm looking at that is that having a narrow skeletal framework, a poorly developed jaw development, makes it easier then for the airway to become obstructed. And my primary job is to relieve the obstruction ASAP, get things unblocked and working properly, but knowing that in doing so, that if there's things such as skeletal compromise, that also needs to be addressed. So what I'm trying to do in a nutshell is I'm trying to find all the problems so that I know what all the solutions are. And I actually take the same approach in adults as well, but let's just focus on kids. So I take the same approach as well, because if I take the cookie cutter approach to kids with snoring and sleep apnea and upper airways resistance syndrome and so forth, which is just to take out the tonsils, just take out the adenoids, I'll get a great result in a good number of kids. The problem is that I'm a perfectionist. I'm my own worst enemy. I want better than a great result. I want the best result that is actually available at the time. And if we're in a situation where a child is having a full general anaesthetic to have some form of surgery, and I haven't looked thoroughly, which means I don't know thoroughly if I'm addressing all the problems because I'm just going and doing the common stuff, then I am opening myself up to failure, which is a great disservice to that child and their family. So if I need to fix the nasal passages, those turbinates, for example, need fixing, I'll fix them. If the nasal septum is crooked and having an impact on the breathing, I'll fix it. If I identify that the child has skeletal framework issues as part of their problem, I will make sure that there is a dentist or an orthodontist on board that understands the problem and is proactive in managing it. I will also look at things like the tongue tie and manage that. And then as part of that all, I'm also looking at what is their general level of muscular function, because when you have disordered breathing, you have dysfunctional muscle patterns that compensate around the problem. And just like if you break your leg and you get the surgeon that fixes the bone who gets all the glory and worship, the reality is it's the person that puts all the time and effort into the rehab that actually makes the thing work better again in the first place. So it's a bit like a racing car driver, you know. The racing car driver at the end of the day is the person that's most prominent for driving that car really fast and winning that race, and it's all put down to them. But you know, the reality is that all the engineers, all the pit crew, and so forth that go into the design, the development, and the maintenance and running of that car are the unsung heroes. Because if it wasn't for them, they couldn't make that driver look as good as what they are. And that's basically where I'm at too, is I've got all these wonderful people around me that make me look good, just by virtue of the fact that I can't do it by myself. I can't fix the skeletal problems. I just don't have that training or expertise. I'm grateful that I can identify them. Likewise, the rehabilitation processes for the dysfunctions, we need that going as well. So it's a team approach. And then sometimes one of the issues is they've got allergy problems. So if a child is so bad that they need surgery for their nasal passages, so this is not their tonsils or adenoids, this is those turbinate things that I made reference to before. If that's happening, where those turbinates got so big, and the most common reason is allergies, we don't want to repeat history. So for those children, I'm a really strong advocate of encouraging the parents to go get them allergy tested. If there's something environmental that is contributing to the problem, an operation doesn't fix allergies. It can fix the swelling and the blockage from allergies, but the allergy is going to keep driving things forwards and try and make more swelling. So get them allergy tested. And then if they come up with an allergy, don't go, oh, wow, they've got an allergy, that was interesting. Get proactive. A lot of the allergies are environmental that you can't do anything about in terms of avoidance. You can, reduce your exposure, but you can't avoid. Get on board the immunotherapy desensitization treatments sooner rather than later. Having allergies not only impacts on sleep because of the obstruction that it causes, but independent of that, it's really, really annoying having allergies, and it's really disruptive to sleep quality. And it's also disruptive to school performance in terms of concentration issues, because you just all the time, and then people are around you, they're, sick of you going all the time, and especially in this era of COVID, it's socially frowned upon to have a sniffle now. We're writing letters for parents saying this child is sniffling because they've got allergies. It's not a cold. They don't need to have a nasal swab every week because their allergies are playing up every week. If that's okay, thanks. So that's my approach in terms of dealing with things. And the other thing, I guess, that I sort of do is as I'm looking out for co-pathology. So in particular, as I've posted before, again, videos about this, their iron levels. Sometimes kids come in and they got all the hallmarks of being tired and not having a lot of energy, but their breathing's fine. They're not mouth breathing, they're not snoring, and you sort of go, right, maybe this isn't one of those breathing ones, maybe this is an iron thing. And sometimes it's both. So looking out for that too. So that's sort of children in a nutshell. Now there was one other one I had. So another thing that I see a lot of, I'm going to talk about adults now. One of the things I see a lot of is with adults, is adults that come in, usually sent in by their sleep partner because they're snoring. And again, make a thorough assessment, because snoring is a noise that's made because either there is something blocking the breathing or there's something moving around more than what it should. So I'm going to look inside the nose and throat, but I always use my nasal telescope in the adults because there's no excuse not to. It's not like there's a compliance issue. It's just basically sit there and off we go. One thing I'll pick up very, very frequently is a deviated septum. And that's where the middle part of the nose is crooked. And when it comes to having a deviated septum, what that impacts upon is the ability to breathe through the nose properly. Again, just going back to my fluid dynamics, okay, in part. So when we have the nose, we have the middle part of the nose. Again, my job's really easy, all right? The middle part of the nose is called the septum. There's two types of septums, straight ones and crooked ones. Crooked one we call a deviated septum, okay? So we have a septum that's deviated. Now, where people get thrown is they go, well, if it's deviated to one side, sure, this side's blocked, but hey, this side's really open, so it's okay. There's a problem. What happens is the nose basically is like a seesaw, a balancing type thing, where if you ever sort of get on the seesaw back in the day when we had seesaws, and you try and get two kids to balance each other. One kid would move a bit closer because they were a bit heavier, so they'd work out that they could balance by shifting their position. Well, with the nose, with these turbinate things, there's this thing called the nasal cycle. And what it's trying to do is it's trying to equalize how much air is going through each side, but it overshoots. So it's like that kid that is adjusting itself and it sort of moves too far one way, so it moves back a bit more. So these turbinates are going like this, but they don't do it quickly. They do it over the space of about 4 hours. So it's what we call the nasal cycle. And what they're trying to do is sort of, from the most open to the most blocked, is to get things the same on each side. So if you have a deviated septum, what happens over time is that the turbinate on the side that the septum is going towards will have a tendency to be smaller, to open up the space, but the one on the open space will have a tendency to get bigger so that things are equal. So you actually end up with a blocked nose. And there's three scenarios when that's the case. Some people notice they get a blocked nose, okay, and they notice it's blocked on both sides. So that's one scenario. Another scenario is that they only notice it's blocked on one side, and interestingly, the side that they tend to think is getting blocked, you realise that both are blocked, okay? The side they think is getting blocked is the side where the septum is actually moving away from, so the open side. And the reason for that is the brain works by relative comparisons. And with regards to relative comparisons, it's a bit like hot and cold. Is it hot? Is it cold? So when you get acclimatized to something for a while, you don't really notice the temperature anymore. You know, you first get into a hot shower and you go, oh, that's a bit hot, but then you get used to it. Or likewise, a cold shower, whatever. You know, cold water, if you go for a swim, you go, oh, that's a bit cold, but then you get used to it. It's because there's no comparison anymore. When it comes to the nose, so when the septum's deviated that way, this side is pretty much blocked most of the time, so that becomes just the normal state of affairs. And then when it comes to the turbinate on this side can go up and down still, you have times where the airway is open, and because it's open, it feels good, but then when it gets bigger, it feels blocked. So sometimes they'll notice that it's blocked on the good side, inverted commas, good side. And then the third scenario is they don't even notice that it's blocked at all. They have basically a sensory amnesia. Again, similar to if you were to get into a bath and where the water's the right temperature, just by the simple law of thermodynamics, that water temperature is getting colder, it's losing energy, it's getting colder from the very moment that you get into it, it is getting colder. But it's doing it very slowly, very slowly, very slowly. Imagine if you were to sit in that bath for 10 years, okay? The water temperature, you'd get very used to it. You wouldn't notice it, okay? The other sort of way of understanding it, for example, is that from the age of 5 to yourself as an adult, you grew taller. You know that you grew taller. You didn't feel that growth. It happened very slowly, very incrementally. So you got used to it. And it's the same with the blocked nose, because the other thing that can happen with this deviated septum is when it's off course, just because it's off at that point doesn't mean it stays like that. There's this awful thing called gravity that gets all of us, okay? So everything drags and sags when it comes to gravity. And the septum does the same, and it will slowly, slowly, slowly get worse and worse and worse over time, okay? So it's not just a fixed point of problem, it's a progressive problem, but because it's so small and incremental, you don't notice it. And so a lot of people have this sensory amnesia, and people are starting to sort of, for some reason, I'm not sure why, get it more so than they used to, because they come and say, look, I'm snoring, I'm mouth breathing, and I go, look, does your nose feel blocked? And they go, no, but then it's been like this for so long, I wouldn't know anything otherwise. And we have a look and go, yeah, look, it is actually blocked. And these people are so remarkable when we sort of go and fix them. They wake up and they go, oh, wow. This is obviously just the sheer delight of actually getting oxygen to their brain again. But you just go, I had no idea it was this bad, and I wish I had done this sooner. So adults can have a blocked nose and be so accustomed to it and so normalised to that being the case that they are completely oblivious to the fact that that is actually going on. And having a deviated septum is tied in with a whole range of things. I actually put something up last night, just following on from a conversation I'd had some time ago with a cardiac heart nurse. Having a deviated septum just by itself, forget about snoring, forget about mouth breathing in the mainstay. Having a deviated septum increases your chances of having an irregular heartbeat, what we call an arrhythmia, of the nature that you may need lifelong medication or may need electrical shock therapy or special what's called ablative therapy to the heart because of that irregular heart rate. And what happens sometimes actually is that people have this blocked nose underlying tendency but not actually had the heart rate problem, and they'll come in and have surgery, and with the medications that we use and because the heart was fragile, that can actually trigger them into an arrhythmia which was never there before, simply because their heart was vulnerable or primed or susceptible to it. And that can be the first time that it sort of becomes evident. They go, oh, well, you caused my heart to have a problem now. It's like, well, no, actually what was going on is that you had a condition that was priming your heart for this. This was just the straw that broke that back in terms of this now taking a life of its own. So it can cause that. It can cause deviated septum can cause high blood pressure. It can cause high blood pressure in what's called the systemic circulation. So when they do the blood pressure cuff, that's the blood pumping through general parts of your body. But it also pumps blood through the lungs. That's called the pulmonary circulation. So we have pulmonary for lungs and systemic is everything else. So you can get high systemic blood pressure, high pulmonary blood pressure. You can get the heart struggling and the heart failing, all because your nose is blocked. And the research shows when we go and unblock those things, it can have a beneficial effect to those cardiovascular conditions. So that's just a little bit about adult deviated septums. Now, when it comes to the conversation some more, I just have a scroll through. There we go. We need to weigh up, what we do in, people in terms of risks and benefits. Now, you've got to be realistic in the world. Nothing that has a benefit comes without risk. You have a great benefit that you can get in your car and you can drive 60 kilometres per hour and be at somewhere far quicker than you can if you had to walk or ride a horse. So we have a great benefit. We also have a risk. Back way before cars and so forth, when people walked most of the time, pretty safe walking. Not much went wrong. The advent of cars changes things. And from that point of view, the benefit of driving, it comes with the risk of having an accident. So the benefit of treating airway obstruction comes at a risk of complications. And the risk of complications when we're doing surgical things is very straightforward in terms of broad categories. The anaesthetic and the procedure itself, okay? From an anaesthetic point of view, in the first world country privilege that I have, knowing that not everyone in the world shares such privilege, we have excellent training, excellent specialists, and excellent medications. So the chances of something going wrong under those circumstances is very, very low, and the skill set of the specialist to manage those problems is very, very high. So I've seen so few problems that have transpired in the 20 plus years that I've been doing this, and seen them all being managed, when they eventuate so thoroughly competently by our specialists and our highly trained and skilled nurses, who, by the way, deserve an extraordinary shout out. They are, the unsung heroes of healthcare. And deserve far more credit and a pay rise for the fabulous work that they do. That's a distraction, but it's true. To what I was saying, so you have the anaesthetic side of things, and then you have the surgery side of it. Now, obviously, it depends on the procedure. There's a huge difference of what can go wrong between having a heart operation, a brain operation, and a nose operation or an ear operation or a throat operation. So from that point of view, it depends on the procedure, okay? So let's go through the procedures in general. So what can go wrong with having the tonsils out? You've got to realise, there's a difference between risks and expectations, okay? Expectation of having the tonsils out is you're going to get a sore throat and have a miserable child who at some point is not going to eat and drink, be absolutely beside themselves, and thoroughly distressed as part of the recovery process. That's not a risk, that's an expectation. You pretty much be sure that's coming. A complication is where something actually goes wrong to the point that you've got a problem, okay? And it sounds terrible, forgive me please, but having a child that is sore and miserable and doesn't eat for 2 to 3 days is distressing, but it's not in the category of a problem in terms of emergency. Oh my gosh, this is serious. It's temporary. It's a temporary expectation that they will get through. Just ride it out. It'll bounce through, you'll get fine. So when it comes to tonsil removal, the main risk that we worry about is bleeding. And a little bit of bleeding is normal, but any bleeding that is of a reasonable volume that causes concern is a trip back to hospital. In an ambulance would be advisable to get there quickly, because if there is persistent bleeding of a significant volume, that child may need acute management and care, which could range from a spectrum of the administration of certain medications, the administration of a blood transfusion, and or the use of further surgery to stop the bleeding. Now, as dire and terrible as that all sounds, that's pretty rare these days. And the thing that really has swung to our greater benefit is the medication. We have medication for bleeding now that we can administer. That means the number of times we are going back to the operating theatre is negligible. And we nip it in the bud early so that they haven't lost so much blood that they actually need a blood transfusion. Really, blood transfusions are so rare that it's obviously a concern and consideration. But they shouldn't be as a source of concern in the big scheme of things in terms of the conversation. So you want to focus on what's most relevant from that point of view. So that's tonsils. Adenoids. What can go wrong when you have adenoids out? The answer is not much. You can get some very rare things going on because we're operating at the back of the neck, which is the front of the spine, or sorry, back of the throat, which is the front of the spine. Having some of the muscles around the spine getting irritated and going into spasm. Very, very rarely you can get swelling that causes some weakness, or what we call laxity, which allows some movement of the spine more than what it should. Very, very rare cases where such children have needed special treatments provided by spinal specialists because of that, but we're talking about hen's teeth stuff. Again, keep the big picture. So not much. The nasal septum, the issues with nasal septal surgery is primarily with regards to developing a hole going from one side of the nose to the other. Now, if you get this hole at the back of the nose, it really doesn't matter. If you get it at the front of the nose, it tends to be more of a problem. And it's only a problem with regards, in a general sense, to symptoms such as a bit of a whistling noise with breathing, and also a bit of a problem sometimes with the sort of nose running and dripping a bit and getting a bit crusty, sometimes bleeding. But again, pretty rare stuff, so again, not to get focused on too much. And then we have the nasal turbinates. And there's different types of surgery for nasal turbinates. So there's this thing called cautery, which is a burn. Usually not much goes wrong. There's a few very rare cases where that burn has caused the bone within the nasal turbinate to lose its blood supply and die off. That's very, very rare. So again, it's not, I'll answer the question, but put everything in perspective. There's a tool where we can melt tissue. So that's called radio frequency. And again, not much goes wrong with that. And then with those two procedures I've mentioned, again, there's an expectation that the problem will come back. That's not a complication, it's an expectation. You just need to be advised and counselled about how that plays out. And then we have turbinate reduction, where we make the turbinate smaller. And the reason we make turbinates smaller is because they're contributing to airway obstruction. If the turbinates are a normal size and we go and cut them down smaller, that's actually not going to help the breathing because it wasn't a problem in the first place. So one of the sort of complications of that is having an outcome that's less than desirable because it was an inappropriate procedure in the first place. So there's that. And again, it's not a complication, it's an expectation they're going to get a blood nose. But again, it's short term, they get better. So that's sort of that in a nutshell. Let's have a look, see. I'm going to round it out because I did advertise that I was going to do this till 8 o'clock. Next one I got, teeth grinding and airway obstruction. Here we go. In a nutshell, can't breathe properly, oxygen level drops. Sensors detect that oxygen level is dropping. Brain, reliant on oxygen, reflex mechanism is to send a signal to the heart to increase the heart rate and the contraction strength of the heart, which raises the blood pressure, which means more blood flows to brain. So that is good. Problem is, blood pressure goes up. Blood pressure goes up too high, overshoots. There's another receptor that measures that pressure level around the heart, says, hey, this is too high. Different message up that says, calm down. You've overdone it. Part of that signal then goes through into what's called the trigeminal nerve. Trigeminal nerve is a little nerve that comes out and goes to 3 parts of the face, top, middle, bottom, and it's the sensation. So when you scratch here, there, or there, that's the 3 branches, which is the trigeminal nerve. The third nerve, or third part of the nerve, the bottom one, also goes to the muscles that move the jaw. So what seems to happen is that the signal gets transmitted down through the trigeminal nerve into the motor part, rather than anything else, that they then start grinding their teeth. So, so from that point of view, that's how it works in a nutshell. And then when kids turn up and they're grinding their teeth, and we as ENTs identify there's an airway problem and get that airway problem sorted, 80% of the time the teeth grinding disappears. So the teeth grinding was a symptom of something else. So that's the teeth grinding. Now I'm looking at the time, so I'm running the gauntlet of time here. So let me go. Any evidence breathing difficulties are linked to mental health issues? Yeah, absolutely. Anxiety in particular. But let me give you the list. The answer is yes. And I actually wrote about this in my second book. Okay, so I've got 2 books now. So my first book was called Snored to Death, which is more about the clinical side of things, you know, in terms of why we get it and so forth, and how we assess it and how we treat it and manage it. And then I sort of expanded on the consequences of upper airway obstruction in my other book, which is Don't Ignore the Snore. And I went through the mental health things quite thoroughly, I think. Anxiety, depression, bipolar affective disorder, schizophrenia, post-traumatic stress disorder, ADHD and psychosis. That covers around about 90% plus of mental health right there. And it's all exacerbated in upper airway obstruction. So yes, absolutely, it's related. So that hopefully ticks that box. Block nose, yeah. So you don't necessarily hear it in their voice. Certainly at the extremes of obstruction, when they're like this and they've got cold, yeah, of course you'll hear it, but you don't necessarily hear it in their voice to that same degree when it's a partial obstruction, because I can block half my nose, okay, and it's very different to blocking all of my nose. So if I'm blocking half my nose, you can sort of notice a bit of a difference, but if I was to change my voice and compensate around it, I actually sound pretty much the same. Maybe a bit different, but if you didn't know who I was, you wouldn't know the difference. And I'm going to round this off to the last question. Thumb sucking and obstructive breathing. It's a really interesting topic. There's no definite science, but there's some good circumstantial Sherlock Holmes kind of aha kind of things that possibly draw it together. So let me walk you through it. When you have obstructed nasal breathing and your mouth breathing, you're getting around the obstruction, okay? I talked about this trigeminal nerve before, so it also doesn't just do the face, but it also does the inside. So it's the sensory nerve for inside the nose, inside the sinuses, and inside the mouth, including the top palate. And it seems to be a bit of a calming nerve. Like I said, it sort of seems to be tied in with calming things down. So when they're mouth breathing, one of the things that happens is it takes the jaw down, which takes the tongue away from the top part of the jaw as well. and the top, the palate, seems to like the tongue being there. It seems to be a soothing thing. So we'll see the thumb sucking also in kids that are got tongue ties. It's holding the tongue down. And again, this is not science. This is just observation and speculation. But what seems to happen is that by putting the thumb in, it acts as a bridge. So it acts as something between the tongue onto the palate, hits the palate, gives it that calming message to the trigeminal nerve. So it's certainly an interesting observation, and it doesn't change management. And if they're thumb sucking or not, they've got airway obstruction. They've got airway obstruction. But yeah, it's interesting. So there you go. Cool. Okay, so I've got one last question just because it's snuck in, and I'm going to let this one go, but then I'm going to call it quits, guys. Trigeminal neuralgia related to airway issues, not directly, but indirectly yes, and that's only by virtue of the fact that having an airway problem can change your sensory perception. And again, I put this in my other book, Don't Ignore the Snore, where I talking in the context, I was talking about fibromyalgia, which is a condition of sensory perception to pain, and one of the things when you have upper airway obstruction, then that changes your pain perception. So you can get the situation where you've got pain for any reason exacerbated by virtue of the fact that you've got an underlying airway problem. The other thing that's interesting is that it gets diagnosed as trigeminal neuralgia. Sometimes you can have a deviated nasal septum, which is actually pushing into the side wall of the nose like a little sort of knife or spear, which can be what's called a trigger point to pain. And given that it's the trigeminal nerve, and as I said, the trigeminal nerve is inside the nose, that can be it. And essentially we see that in migraines as well as a potential trigger point for migraines. So it's always a good idea to sort of, make the clinical diagnosis, but think outside the square and go, hey, wonder if maybe there's some ENT thing going on, because, me being who I am, it's always related to ENT. That ingrown toenail, oh yeah, that was an ENT thing too. That was a joke, by the way. Anyone that takes me seriously has got too much faith in me. All right, guys, I am going to call it quits because I did dedicate the hour just for this, so that is where we're at. Thank you all for your time. Thank you for your great questions. Hopefully I gave you some reasonable answers. I will try and do my magic so that this can stay up here, so that those that might have missed from some point can join in later on. Cheers.